This is actually a very interesting story and one that's very near and dear to my heart, but adrenal cancer has very limited treatment options, and historically one of the most important drugs in the treatment of adrenal cancer has been Mitotane. Mitotane induces an enzyme called CYP3A4, and most of the TKI agents are actually metabolized through this pathway. And so in the initial study with Sunitinib, which was led by a group in Germany, they found that Sunitinib had very little activity in adrenal cancer. But they went and looked at PK levels of Sunitinib, and they looked at patients who had had exposure to Mitotane, and the majority of patients on that trial had. If patients had any Mitotane in their system, basically Sunitinib levels could not be meaningfully achieved with either Sunitinib or its metabolite. And so we recently published a phase 2 study with Cabozantinib. And in that study, we had very, very modest objectives. We wanted to see if we could have more than 30% of patients treated with Cabozantinib have progression-free survival of more than 4 months. We restricted patients either had no Mitotane or had to have levels less than 2. Physiologic is between 14 and 20 in terms of having Mitotane with activity, so we wanted very low Mitotane levels. We achieved that. We had the PFS4 was 72% of patients, the median PFS was 6 months, and we highlighted that Cabozantinib can have activity. In some of our correlative analysis, we looked at PK levels of Cabozantinib, and even in patients who had had no Mitotane for 6 months, or Mitotane levels that were very low, as compared to no Mitotane at all, we saw major differences in Cabozantinib PK levels. So we think the development of TKIs is going to be crucially tied to Mitotane exposure and has to be really accounted for as we go through next generation trials looking at TKI or combinations.